Hello, everyone. Welcome back to Luncheon with the Experts, the Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer that's been working with the foundation for about 10 years, actually a little more like 11, maybe going on 12 now. So over a decade to create all kinds of video content, like, some like the live video series you will watch today. But also we've done patient-centric documentaries. We have done treatment-based videos, really dense treatment-based videos. We have done event videos, all kinds of content, but all with the same mission in mind, and that is to help spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, the show that you're going to watch today, if you are unfamiliar, is Luncheon with the Experts. And I see the value of this show twofold. We're going to bring you some really great information from a leading expert in this disease. And also, I'm very proud of the community that we've helped cultivate within the show. I mean, within the whole NET community, I'm really proud of the work the foundation has done. But even here on the show, I see how much or how often people are sharing their own stories and experiences and how valuable that is to patients and caregivers and support group leaders as well. So if you are a regular, you're probably already doing this, telling people where you're signing on from. And if you are new, welcome to the show. Go ahead and say hello and embrace that community that I alluded to. They will embrace you back. So as always, Canada is strongly in the house in the States, but let's see how far we can reach today. It always surprises me how many countries are tuning in live when as I said to our guest before we started, sometimes it's even people in countries that should be asleep. It's like midnight their time. So that says a lot about our show, doesn't it? Okay, before we get started, we want to thank our sponsors, always, Ipsen Biopharmaceuticals. Without their support, we just simply wouldn't be able to do the show, folks. And we have this disclaimer from them, and that is that the opinions expressed today by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Lunch with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So audience members should not rely solely on these opinions and this information expressed today by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, a lot of words, but they're really only saying one thing. We're going to give you some good advice, some good answers to your questions, hopefully today, but by no means do we or our guests know your specific case. So take that information, that advice back to your home team, which does, and make the best plan and path forward for you. Because in the past 10 years, if there's anything that I've learned, it's that each case of this disease is unique, and therefore each plan and path forward is as well. Okay, so I'm very excited to welcome a new guest to the show, Dr. Christofer Juhlin. I say that right? Did I do okay?
Perfect.
So Dr. Juhlin, first of all, he's very lenient with us Americans in trying to pronounce his name. So I think he would have let me pass no matter how I said it. But Dr. Juhlin, tell us a little bit about yourself for those who aren't familiar with your work and like the role that you fill in this NET community.
Well, thank you so much, Rain, for having me on this show. So my name is Christofer Juhlin, as you would pronounce it. I'm an MD, meaning that I'm an endocrine pathologist. So I'm specialized in diagnosing endocrine tumors, including neuroendocrine tumors. So that's what I do for most of my time. When I'm not working with diagnosing tumors through my microscope, I'm actually investigating the DNA and the protein of these tumors in the research lab just across the hall here. So I'm a PI of a research team that focus on neuroendocrine and endocrine tumors, and we're trying to improve both the diagnostic and the prognostic aspects of these tumors, because we know that there are more things to be done in this area. And there are some questions that we encounter these questions during the clinic, and then we try to sit down and try to solve it in the lab, basically. So yeah, that's pretty much what we're trying to do.
Great. I'm excited to have a pathologist on the show, and I know that our team is. So because we get questions about this every week, you guys. So, Dr. Juhlin promised that he would field any question that you asked him, but really the benefit that you're going to get today is talking about those topics in which he specializes. So diagnosing or being diagnosed in this disease, and less about the treatments. But go ahead and start sending in your questions. We're going to try to get to them, but that's really going to be where the benefit comes from in this interactive one-on-one session. And that being said, this video will live as soon as the video is done, the broadcast is done, it will live here on the videos tab. It'll be evergreen. On Monday, we'll put it on YouTube for people who don't have Facebook. So you can always watch the replay, or if someone isn't here, they can watch the replay and get a lot of value out of it. But the real value is being able to get across a question to our guest today that you've been struggling with, or your team has been struggling with. So if you know someone that should be here, or maybe they've forgotten, you normally see them saying hello from Chattanooga or wherever. I just made that up. I mean, it's a real place, but I just used that as an example. Go ahead and tag them in the comments. Let them know the show's going on. Send them an email, call them, whatever you got to do. Get them in the house. We want to get as many people here as possible. One other thing that I'd like to ask you to do, and I do this every week, and you all do a great job, is if you see a question or comment that you also have, or you're interested in the answer to, you can simply just under the comment section on Facebook, you can like that question, love it, whatever emotion you want to use, but it does the same for me. It effectively upvotes it. I see there's a demand for that question. We get so many questions, we inevitably can't get to them all, which is a good problem, essentially, because it allows us to keep the show going every week, but we want to get to them. But if I see that there's a question that 8 people have, I'm going to really make sure that we get that one across in today's episode. So that just helps me do my job a little bit. And I appreciate you so much for it. So go ahead and start sending your questions. Dr. Juhlin, I have a few questions for you myself. I just want to get to know a little bit more about your journey in this disease. I'm always very interested in this. So I ask this question often. It's like, I don't feel like anyone just happened to fall into the NET space, right? So tell me a little bit about how you got there, how, what percentage of your patients are NET patients, but I'm curious, like, what was the path, the story that led you here?
Well, that's a great question, actually. And the reason why I started out doing endocrine pathology was basically that when I started my medical training, there was a great professor here at Karolinska named Lars Grimelius. And he was, and he still is, a world famous pathologist because he was the inventor of the Grimelius silver stain, which was the first way to stain a tumor and tell if it's neuroendocrine or not. So before that, there were not really easy to tell whether or not a tumor was neuroendocrine. But with his silver stain that he developed and also implemented in clinical routine, that made it possible for us to tell whether or not the tumor was neuroendocrine. And this is way back, but that was what made him famous. So he was a real superstar when I was a medical student, when I met him. So I was starstruck, and he also showed me a lot of pathology early on. He showed me these slides, and you had this bunch of pathologists gathering around him when he started talking about these tumors, and he was so enthusiastic. So that's my first real experience with endocrine tumors. I knew that this was something really special because this is something new. And in fact, Karolinska, the hospital that I'm working in, was quite world leading in that aspect, and Uppsala as well, the neighboring hospital, because they developed this technique first. So that made it all very simple for me to choose a path. I wanted to walk in his footsteps. So when I started doing pathology, he was still around, although he was in his late 80s doing pathology. So he started showing me these basic tricks. And by that point, of course, pathology has developed. There's no longer just a silver stain. We have immunohistochemistry and other techniques to show whether or not a tumor is neuroendocrine. But he really started us off in a great direction. So he inspired me to become an endocrine pathologist. You can definitely say that. And so I'm a dedicated endocrine pathologist, meaning I'm diagnosing endocrine tumors. So that's what I do. So that's basically tumors of the thyroid gland, the adrenal gland, the pancreas, the parathyroids, all different glands in the human body that may secrete a hormone or a peptide. I will diagnose it if there is a tumor in it. And so basically, I would say my work is more or less dedicated toward neuroendocrine and endocrine tumors, basically.
Got it. Thank you for that. It's often that the journey, I told you I asked this question a lot. It's often that the journey started with a mentor, and that's probably true with any journey or any story, right? But especially in this disease, because I don't think a lot of people start off thinking this is where I'm going. I think that will change now that we're learning so much more about the disease. But this is a common thread. This like, well, I studied under this person who I really looked up to, and they got me there. Those kind of early legends in the space. Listen, I told you that we would probably have some Scandinavia in the house. So Ritva from Finland says hi. Although I think you may have been here before. So if you have, welcome back to the show. Okay, so Dr. Juhlin, specializing in the tumors that you do, what are your most common or most frequent challenges in this specific disease for the work that you do?
That's a great question. I would say there are at least a couple of different challenges, but I would say the prognostic aspect. So the diagnostic aspect and the prognostic aspects. So my job is to make sure that the tumor I'm looking at, is it neuroendocrine or not? That's the first question, right? So there are instances when I'm doing second opinion cases from outside of my hospital where the pathologist in charge tell you this is a neuroendocrine tumor. Well, in fact, it's not. So that's the first thing you have to do. You have to use all the markers, all the skill, all the morphology through the microscope, the genetic analysis that we do, everything, and compile it into a certain diagnosis and say, this is for 100% sure a neuroendocrine tumor. Okay, that's the first thing. So you got to get the diagnosis right. But then it's a huge step from the diagnosis to the prognosis, because I mean, we've been trained so hard to get the diagnosis right, but now we're starting to learn that we can actually tell so much about the patient's prognosis by studying the tumor. So it's not only getting the diagnosis right, it's also that you can actually, with clues from morphology, by looking at it in the microscope, doing your stainings, doing your magical stuff in the lab, we can actually tell the surgical team or the oncologist whether or not this tumor will behave poorly or not, or this patient will have troubles with disseminated disease or not. So when I started out, we weren't that good at it, but with the increased research activity going on, so much more data coming in, we know that we can stratify these tumors into high and low risk. So that's the second job of a pathologist. So not only get the diagnosis right, but also try to stratify the risk, assess the risk of these tumors. I mean, is it high, low, where are we? And will it respond to treatments? So there are a number of analysis that we can do today that we couldn't do 10 years ago that will tell if the tumor will respond to certain specific treatments that are now available.
Got it. Thank you. Yeah, a lot has happened in this past 10 years, this past decade to help us treat and diagnose the disease. So that's exciting. I hope that trend continues. We got a lot of questions coming in, so I'm going to go ahead and start taking some from the audience. But Jennifer starts us off with, what does 5 to 15 mitosis mean?
Well, that's a good question. It means that, well, I mean, usually you have, it's when in endocrine pathology, to grade a neuroendocrine tumor, you grade it 1, 2, 3, depending on how aggressive it will grow in the body. So basically, the more mitosis you see in the microscope, the more aggressive it will be. And mitosis is basically, a mitosis is when a cell is dividing, any cell in the human body. When it's dividing, it lines up the DNA perfectly in a string and then pulls it apart. And you can actually see that with your naked eye in the microscope when the cell is doing this, because you freeze the time, right? When you cut the tumor and you fix it, some of the cells will be fixed in that specific position when they draw the DNA apart into 2 different new cells. So basically that's a mitosis. So if you count them, the more mitosis you see, well, the more proliferative activity is going on. The tumor is growing more rapidly. So that's how we grade them. So when pathologists write in the report that you see 5 mitosis per 2 square millimeters, that's an indication of how fast the tumor is growing, actually, and that's how we grade them.
Can you give us a little more insight on the scale? Like what is grade 1, grade 2?
So it's basically that's different for different tumors, basically, because we have but for the universal grading for neuroendocrine tumors that arise in the all along from the esophagus down to the rectum, there's one way of classifying them, and that's how you count the mitosis. And if it's less than a specific amount of mitosis, it will be grade 1. If it's in between 3 to 10, it will be grade 2. And if it's above that, 20, it will be grade 3, and so forth. So that's how you do it. But there's not only the mitotic count, there's also a marker. You can stain these tumors for an immunohistochemical marker, which is a like a guiding missile, an antibody that you direct towards a protein in these cells. And if it highlights, that's a sign that it's proliferating. That's the Ki-67 index. So we have more or less replaced the mitotic index with the Ki-67 index. So that's, you can use both of them, but people are relying more and more to the Ki-67 index. So basically, if you have a neuroendocrine tumor arising anywhere in the gastrointestinal channel, tract, you will have a pathologist looking at it and determining the Ki-67 index. The rate of proliferation will tell you the grade of the tumor, and the grade of the tumor will dictate future treatments.
Awesome. Thank you. That was thorough and also made a lot of sense for me. I appreciate that. Hopefully it did for you too. Thanks for your question, Jennifer. Next question. Can a tumor be checked for receptors after it is removed?
Yes, that's a great question. That's usually what we do. So
okay.
when the surgeon, or the cytologist or the surgeon, we look at any kind of tissue that's removed from a tumor, either through a fine needle aspiration biopsy or a surgical resection. We take that tissue piece and we fixate it in formalin. And after that, we can actually study the expression of many different proteins or even the mutational panorama in the DNA. So what we can do is that you take the tissue out from the surgery, and then the pathology will gross it. I will cut it into smaller pieces and put it in formalin, cut it very nicely so we can look at it in the microscope, and then I can order a bunch of stains from these slides. And I can tell right away if there are any kind of receptors that the oncologist would like to know are present. We can stain for them and we can tell whether or not they're present. And that's also building on what I talked about earlier with the prognostication. Mm-hmm. So there are numerous markers now developed that gives you the ability, the pathologist will actually stain for these different markers, these different receptors, and that will give you an indication whether or not it will respond to different specific net treatments, or if it will light up on radiology or not. So that field has evolved immensely. So yes, we do that on the surgical resected specimens all the time.
Got it. Thank you. And thanks for your question. Moving on, from Michael, who had a lung carcinoid. He said, should I be interested in reviewing my pathology report from 1998? I had a metastasis to my adrenal gland and liver last year.
Okay, thanks for that question. I'm sorry to hear that. So basically, while I'm not here to give like specific medical advice for this specific case, this is an interesting question that Michael puts forward, namely, should you review the pathology reports if it has been 5, 10, 20 years since the original diagnosis? Well, to me, that's a discussion between you and the treating physician, basically. So discuss this with your with your oncologist. My experience is that while some of the grading schemes have changed and some of the ability to look for new markers has changed as well, the diagnosis performed 10, 15 years ago is still very accurate because the pathologists were really good with morphology and counting mitosis. So the grade and the overall diagnosis is usually correct, of course, but we can do so much more today with prognostic markers. So we have a number of patients at Karolinska. They have been operated for 10, 15 years ago, and now they develop metastasis. So what we do is that I review the original report and I review the case, and now I can do some molecular workup. I can stain these tumors for receptors and markers that we didn't have 10 years ago, and we can stain for them now and tell whether or not additional treatment like personalized medicine can be an alternative. So that's always something you can discuss with your oncologist.
Got it. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts at Carcinoma Cancer Foundation program. We're here with Dr. Christofer Juhlin, and we are talking mostly about pathology, but great questions already, great answers from our guests. So let's keep the show going. From Brian, with your diagnosis and prognosis, do you give recommendations? This is an interesting question. Do you give recommendations of treatment to the medical team seeking this analysis?
Yes. So that's a good question. Thank you. Yeah. So the pathology team is really integrated into the entire clinical team in modern day practice. In my hospital, we have and most hospitals in the US as well, I know, have these weekly or bi-weekly tumor board meetings in which you sit down and you discuss these difficult cases. You have radiology, represented surgery, oncology, endocrinology, and also pathology. So of course I'm allowed to speak. I'm a medical doctor just as them, so I'm allowed to raise my voice if there's something I want to discuss. And sometimes, yes, I do have important information I want to share. So I'm not sure we're going to discuss that too much, but we have these really horrible, poorly differentiated neuroendocrine carcinomas, the worst type of NET tumors, basically. So there's little hope for some of the patients that receive traditional chemotherapy. So what we do now is that we try to interrogate the DNA for actionable mutations, changes in the DNA that would allow them to be treated with some specialized medicine. And that's usually that's the analysis that the pathologist will do, and then tell the rest of the team, hey guys, we found this mutation in this gene. We have a drug that fits directly into this mutation. Should we try it? So basically, yes, we're allowed to, and that makes the whole line of care more effective, in my opinion.
Absolutely. Great question. Thank you for that. From Linda, if you have a NET removed a couple of years ago, so 2019 in this case, can you still have a second opinion done on the specimen?
Yes. Great question. Yes. So when you fixate something in formalin and then embed it in paraffin, it's there for eternity if you want. So I mean, we have cases in our files from Karolinska from the 60s and 70s. So they're still there. You can just bring them up, cut new levels, and then do the analysis that you want. So I mean, as I told you earlier, some of the diagnosis or some of the patients that we are treating, they had their original diagnosis 10, 15 years ago. So we always bring up the old specimen and restain it for new markers to see whether or not it will respond to different treatments. So yes, you're able to do second opinion cases, even though you're operated at 5, 10, 20 years ago. It's still possible. We keep everything.
Awesome. That's good to know. Another great question. You all are bringing it today. I love it. I love it. Okay. Next question from Gwendolyn. Gwendolyn says, okay, going into a surgery and biopsy, is there anything that you would recommend requesting the pathologist look for if you are not at a NET center?
Great question.
Right.
Yeah, great question. So, I mean, as a pathologist, we're always happy if we get guidance from the clinician or the person taking the biopsy or removing the tumor or whatever. So, I mean, we always have a dialogue. That's for sure. You need to have a dialogue about this. So I would say if you're not in a NET center and you will have a tumor removed or biopsied, well, yes, it could be of value, of course, if the surgeon or the oncologist specify what they need to look for. But usually this is pretty straightforward. It's in the guidelines. We have these NET guidelines in the US and in Europe that pathologists should follow I mean, in terms of what you need to grade the tumor. That's what I was talking about. Look for mitosis, do the Ki-67 index and so forth. But there might not be, you might not have access to all the stains and all the molecular workup that we do in a tertiary center. So that's the problem. So there might be some analysis that you would need that's you're not able to perform in all the centers. But in those cases, it's easy to submit the case for second opinion.
Got it. Thank you. Great numbers today, folks. Our room is filling up and we've got plenty of time on the show left. We're not quite even halfway done today. Okay, so Dr. Juhlin, I have a question from Jennifer. It's a big question, kind of vague, but a few other people have it. I want to try to field it if we can, because I know people struggle with this. Jennifer says, why do my doctors look at me like I'm crazy when I mention receptors and ask in-depth question about nets? And so I know this is something people experience, and I want to see if you could take a stab at it.
Well, I'm sure you're not crazy, and I think
right.
What I've heard. I mean, so I'm a pathologist. I don't meet that many patients. I meet patients when I do the cytology, the biopsy, and stuff like that. But right. I'm not the treating physician. So, but what I've heard from my colleagues that NET patients are educated. They read a lot about their disease because it's a zebra, right? It's an unusual disease, so you have to read up yourself. Because some of our patients, they have been wandering around in several years or months before obtaining their correct diagnosis. I think it's even on your webpage. If you don't suspect it, you can't detect it, right? It's so important to detect it early, right? Yeah, that's what you should do. And so many of our patients, unfortunately, have been struggling with this, have been talking with doctors and may not have been heard. So I think that's just the NET patients are an educated group of people, and you're not crazy. And I love that you are well educated, and you should discuss with your doctors, and you should ask provoking questions, because you might even move the agenda forward, because you might even know more about these receptors than some of the doctors. I'm sorry to say. I mean, we don't know everything. I mean, we know a lot about some things, but I mean, so go ahead, read up and ask your MDs all these questions. And the receptors, I mean, that's a great question. We've only in the recent years started to stain for these. If we're talking about these somatostatin receptors that are usually, we look at them to see whether or not a tumor will respond to somatostatin analogs, which is one of the most common treatment for NET tumors, except for surgery. So, I mean, that's just a great question to ask. Did you stain my tumor for these receptors? Was it positive? Was it negative? Because if it's negative, what's the point of giving me this drug? Ask these questions.
See, I knew the question wasn't exactly perfect, but I'm so glad I asked it. Like, what I really appreciate that. I got a little emotional hearing that, folks. And I saw other people did, because you can't see it, Dr. Juhlin, but they send little heart emojis and stuff when they were responding. So, folks, if you like that answer as much as I did, write zebras in the comment section. But yeah, that's outstanding. And I think it's such a good point. You're not really going to meet a lot of NET patients that are going to sit by and just like listen to what you tell them. They're doing the work. We're helping them. And I completely agree with you. Just, that was beautiful. I appreciate you very much. And Jennifer, keep fighting the good fight. We're proud of you.
Thank you.
Yeah. Okay. From Misty. Can neuroendocrine cause other cancers to grow? Also hear this question a lot. I have two different cancers in my body, neuroendocrine and adenocarcinoma of the stomach, per my pathology report. So is there some connection there?
Yes. I mean, there are a certain subgroup of patients that will have two collision tumors, two different tumor types in the same lesion, so to speak. We call them collision tumors. So there's a specific name for that kind of tumor, in which you have two different elements. You have a neuroendocrine element and you have an adenocarcinoma element, or it can be squamous cell carcinoma. It can be any type of cancer mixed up with the neuroendocrine tumor. But we know so little about these tumors because they're very rare when they are colliding in the same lesion. So we don't really know that much about the genetics. We don't know that much. What we do know is that we usually go to treat the tumor component with the highest grade. So if it's a neuroendocrine carcinoma and a more or less low grade adenocarcinoma, we'll try to treat it as a neuroendocrine carcinoma. That's my experience as a pathologist. There might be experts out there saying I'm wrong. I don't think I am completely off, but I mean, that's the general rule. Then, I mean, is there an overrepresentation of other tumors in NET patients? Well, that I'm not sure of. I'm not the guy to ask in this specific instance. You could, I mean, at least think that NET patients are usually followed for so long, so they will have, I mean, consecutive and subsequent radiology reports. Like you will be imaging the abdomen and the pulmonary tract for like decades for some of these patients. So of course there will be an increased risk or chance to discovering incidental lesions that are totally unrelated as well.
Got it. Thank you. Okay, from Jim. Jim has two questions. First, I have starry liver. I get MRIs every 3 months to monitor progression. Should I be getting other imaging periodically? Should we be scanning other areas for early detection of potential spread?
Yeah, that's a great question. And again, I would really like you to discuss that with you, of course, your treating physician. And it still puts it in an interesting perspective. I mean, there are radiology programs for all different types of NET tumors, and usually that's what the treating physician will follow. So there are specific radiology programs in which you should follow. You should have this radiology at month 0, and then you should have this at 6 months and this at 12 months and so forth. So usually you follow a specific program which has its origin in studies. So there are often studies, scientific studies being performed that these intervals are leaning on. So basically, I think what patients should really know is that these screening programs, while the individual case, you might have cases in which you're missing something between radiology intervals. For most patients, that's not the case because it's built on solid research. I hope that was the answer to your question. I'm not sure.
Yeah, Jim, let us know if not. And then his second question, Dr. Juhlin, was also, I'm lacking in somatostatin receptors. Is this something that can change over time?
Yeah, that's a great question. Thank you for highlighting this. So neuroendocrine tumors are dynamic in a temporal aspect. So if you take a biopsy of a tumor in 2010, and then you take a rebiopsy of a similar liver metastasis in 2012, 2 years later, it might look completely different. It might have increased proliferation, more mitosis, as we talked about earlier, higher Ki67 index, so it will grow more rapidly. And the expression of various proteins might also change, because usually what happens in tumor biology, when you have a tumor in the body, it will accumulate mutations, DNA damage, and that will cause the tumor to change. Some of the receptors that is usually expressed will not be expressed in later years, because it will have a tendency to down-regulate stuff that it doesn't need anymore. It's like in the beginning, all tumors are fairly well differentiated. That's the thought, basically. You have all this expression. It looks like a neuroendocrine cell, but then in the end, when it starts to de-differentiate into something else, it might actually lose some of the potential to be a neuroendocrine tumor. And so this is highlighting some of the work I've been doing in later years, because some neuroendocrine tumors might actually lose the ability to secrete these various peptides that we were talking about, meaning that if you stain them for chromogranin A's and apophysin, these normal neuroendocrine markers, they might even be negative. So you might have a neuroendocrine tumor, looks like a solid neuroendocrine tumor, no worries, 2 years later, starts to lose the expression. So the pathologist starts to get worried. Is this a second tumor? Is it the same tumor? Is it still a neuroendocrine tumor? So tumors might de-differentiate, and they might lose their expression of these receptors that we've been discussing as well. That's true. So that's why the oncologist is usually quite keen on getting another set of biopsies. So you should have a new biopsy. Why do I need a new biopsy? I had a biopsy 2 years ago. Well, the tumor will change. So the proliferation rate might go up. So you might need another drug, or we might need to intensify the treatment.
Got it. Thank you. Next question from Karen. Do all pathologists know how to deal with rare cancers? I had a tumor removed in 1998, and they had a question mark as to what it was. At that time, they called it benign dermoid. Okay.
Yeah, no. I mean, we're just human beings. Pathologists are human beings, just as the rest of you guys. So, I mean, some of us are specialists in certain areas, and some are general pathologists. So general pathologists working outside of tertiary centers, that's not me. I'm the opposite of that. I'm highly specialized, so that's why I only see NET. If you would put me to diagnose like cervical cancer or colon cancer, I would do a horrible job. So I am not even going to do that, right? So, I mean, we're still trained to do the basic stuff, but we are specialized for a reason. So the general pathologists, they're excellent in, like, they have a broad coverage, a broad knowledge base, so they are able to pick up neuroendocrine tumors mostly. But when you want them to do the extra work, I mean, the grading and the receptor and all these prognostic markers, that's when we come into the picture usually. Not all these centers have these markers, so usually you have to submit the case to us, to a tertiary center. Not always, but so yes. Not all pathologists are trained at rare cancers. Of course, some of them are just general pathologists that are excellent in screening. They see so much benign, they see so much malignant from all different parts of the body. So they have a general conception which is really good, and I could never compete with that. But in the end, of course, they will not be as skilled perhaps in detecting some of these rare cancers that we are.
Got it. Thank you. Thank you, folks. We are just a little bit more than halfway done, so plenty of time to send in questions for Dr. Juhlin. I'm really enjoying today's episode. I hope you are as well. So Dr. Juhlin, here's another question that I might not normally ask you, but now that I know the level of empathy that exists within you, you're getting them all, my friend. This is such an important question, so I want to talk about this. This is from Vicky. As a caregiver, how best can we support our loved ones with this diagnosis? And I know that's a big question, but I feel confident that you may be able to tackle it.
Well, this is a great question. As a caregiver, how can we support our loved ones? Well, I mean, as with any disease, I would say you would need to, show, dedication to your loved one. Talk with them, ask them questions all the time. Don't be afraid to ask questions. Be there for them. I think what I heard when I was in medical school, what cancer patients, what they tell doctors and their relatives most is, why didn't you ask me how I was? If you have a colleague in your department who will get cancer, well, people will think all of a sudden, this is very private. I won't ask any questions. No, this is too private. I will not step over that line. But then in the end, when you talk to them afterwards, some of them might say, why didn't anyone come by my office and say, how are you? Why didn't you just tell me, how are you? Talk about your disease. Come on. It's not a shame. You haven't done anything wrong. It's just you've been innocently struck with a disease that, if you broke your leg and walked around in the hallway, everyone would ask you, what happened? Oh my God, can I bring you coffee? Can I do something? How's your leg now? When will you remove the cast? But with cancer, people are, oh, no, I'm not going there. That's my experience anyway. And so ask questions and ask them, do you want to talk about your disease? Do you want to talk about how you feel today?
That part, yeah. Yeah, you can give them the option too. That's the thing. People assume that they don't want to talk about it or it's too tough or whatever. This is such a good, just ask, like, how are you feeling?
If they don't want to talk, they can just say, no.
Yeah, you know what, I'm feeling down today, whatever it is. And this is the same thing, with loss as well. When people are kind of, they're shy, to ask about it. And once you've experienced it, it makes you a little more direct because you've been there and you understand that sometimes people, they do want someone to ask. This is why I asked you that question. I appreciate that. I totally agree. Okay. Next question from Donna. I know you haven't seen a lot, you don't see a lot of patients. You already mentioned that. But here's another question about the connection between different cancers. Have you seen patients, a few, many, any, who have been diagnosed with breast cancer and then NETs? I was treated in breast cancer in 92, 97, no evidence of disease since, and a NET diagnosed in 2007, originally in small bowel. And I'm repeatedly told there is no connection, just bad luck. What do you think? And I'll tell you, Dr. Juhlin, this is not the first time by far that these two specifically have come up together in questions.
Yes, you're completely right. First of all, while I don't see patients, when the patient is under my microscope or the tumor is under my microscope, I will call them my patient because I care for them. In fact, the pathologist is the doctor that all you NET patients have had, but you're not really aware of it. I do see the patient in a way. I read up on the patient stories and everything, and I do see this connection. I do see a lot of patients with breast cancer that also have a NET tumor. If that's biased in any way, it could be because breast cancer is one of the most common cancer types in the human body, right? And I see a lot of NET patients. So of course I will see a lot of NET patients with breast cancer. If there is an epidemiological connection, I'm not your guy to answer. There might be studies trying to, I don't think there is like a clear-cut connection. There's no tumor syndrome in which you develop both tumors of the breast and neuroendocrine tumors of the small intestine. There's not. But if there is a connection, I'm not sure. Once you're a cancer patient, you will go in a surveillance program. So of course, it will be easier to detect small lesions in the rest of your body when you do the scannings. So there might be a biased way of actually detecting these NETs more rapidly than what would otherwise be the case. But you're completely right. We see these patients quite a lot. You have one tumor and then 10, 15 years later, you develop a neuroendocrine tumor.
Got it. Thank you. I appreciate that. Next question from Jennifer, who's been very active today, and I appreciate you for that, Jennifer. I always love when people are taking advantage of the show to the maximum ability. Jennifer says, you stated that you can provide prognosis. What is this called within a report? For example, I'm grade 2, but surgery removed all the tumor. Lymph nodes negative, but pathology could predict if it comes back?
Great question. Yes. We don't actually, so the prognosis of a NET patient is based on the grade of the tumor, which we've been discussing, right? Mm-hmm. How fast it's proliferating, how fast the cells are dividing, which we can measure, right? That's the grade. Then we have the stage of the tumor. How far has it spread? That's also included in the pathology report. So if the tumor is only if it's well contained within the, let's say it's a pancreatic neuroendocrine tumor, if it's confined to the pancreas, well, it gives it a lower stage than if it grows through the pancreas and out in the surrounding fat, of course. So that will, so you will have a higher stage. So based on the grade of the tumor and the stage of the tumor, we can actually predict how most of the NET patients will do with certain treatment types. So that's so basically by giving the grade and the stage, we're able to design the treatment after that, because we know the prognosis of the patient fairly well. What's happened now, the last 5-10 years, or 5 years, I would say, is that we can now do some other analysis apart from grading them and staging them, because that's old school in my book. Now we can actually also do interrogate the tumor DNA to look for specific changes that are that we can actually use for treatment of these patients. And there are also some of these mutations that we can see. If they have those mutations, we know, oh, this means trouble. This is a trouble mutation, or this mutation confers a better prognosis. Especially for pancreatic neuroendocrine tumors, we know that there are a certain set of genes. If they're mutated, we're more likely to call them neuroendocrine carcinomas than neuroendocrine tumors. So they're more aggressive if they have these mutations. So we're getting there, and we're starting to just amassing the evidence, and we're starting to compiling it now, but most centers are not actively doing that because it will be very time consuming to sequence all these patients, of course, but we're getting there. And my vision as a pathologist is like in 5-10 years time, all NET patients will have also a DNA mutational summary in the report. Not only the histology and some immunohistochemical markers, but also a molecular report stating we have this and this tumor, we have this mutation, and this confers this prognosis. And we're able, the technique is already there. It's all about logistics.
Got it. Thank you. I see a lot of response for for this previous answer. So people are really appreciating the information you're giving us today. We talked about this disease being dynamic. Jean has a question. Can the same tumor change to a higher grade, or when a higher grade is detected in the same tumor, is it just another portion of that tumor was sampled?
Yeah, great questions. I mean, just exemplifying that NET patients are really well.
Seriously.
These are like PhD level questions. I love it. Well, you're completely right. A tumor might change grade. That's a known fact. It might change grade. And also, this is a known dilemma in pathology. Do we need to study the whole tumor? If you resect a 7-centimeter tumor, I will remove a small piece of that and look for the proliferation index to grade it. How come we only look at that little portion of the tumor? What if the proliferation rate is much higher in the other end? So I try to sample different areas, and I look with these stainings and look for the mitotic index and stuff like that to see whether or not. And you know what? There are actually studies coming in that you might actually detect that the tumor might be one grade in one area, but if you look in another area, it's a lower grade. So they might coexist, because you look for proliferation. You should look for the area with the most proliferation, and you should grade it by that. You're not supposed to just look at a random section. Look around. You have to look at different sections of the tumor to see where are the most mitosis hanging around and count them there. Don't count them in areas where there's nothing going on. So that's why we call them hotspots. So we look for hotspots and we count in the hotspots. That's how you should do. But you're not able as a pathologist to sample a whole 7-centimeter tumor. You would kill the entire lab, because it takes a lot to process that amount of tissue. So what you do is you do a selected amount of slides and you process them. So there's always a small, tiny risk that you might not end up with. I mean, I'm just being honest. In theory, you could actually sample areas with lower proliferation, and the areas with the higher proliferation, you're not sampling at all. It is a risk. It's not very common, I would say, because usually we're quite right on, we're right on target, because that's what research is showing us. But it's a great question. It's called tumor heterogeneity. It's a developing area of research. in which you can see that some areas of one tumor might have a different set of mutations than another area of the same tumor. So even within the tumor, there are different clones with different mutations, and they will have different proliferation rates. So how would you know which clone to look for? So we have a lot of work to do.
Yeah. Got it. Thank you for that. Next question from Gwendolyn. What are the prognostic markers?
But that depends on the neuroendocrine tumor, basically. So there are different neuroendocrine. You have neuroendocrine tumors of the thyroid, the pancreas, all around the GI tract, also the adrenal glands. So it varies with the tumor tissue of origin. That's the first thing I want to say. But there are, apart from the Ki67 index, which is the most degrading marker that we use, there are a number of markers that we use, and especially for I don't know if there are any patients out there listening now that has a pheochromocytoma or paraganglioma, which are rare tumors of the adrenal gland or paraganglia. But in those instances, we have a number of stains that we can do on the tumor tissue to give us an indication whether or not they have a specific mutation, which confers a much higher risk for metastatic spread than other pheochromocytomas. So we know for a fact that if the tumors lack those markers, we know that this is high risk of metastatic spread. And that's something we do in the pathology lab when we have those tumors in front of us. That's just one example, but it varies with the tumor type. But I would say there are prognostic markers for each and every one.
Got it. Thank you. Are you familiar with it? So Ruby says, I've been told that I have ground glass nodules in my lung. Can you tell me what these are? You familiar?
Yeah, that's a question more suitable to a radiologist, but basically that's a specific imaging finding. That's what the radiologist sometimes will see. It looks like ground glass appearance. It's a specific sign, and it could basically tell you different things. So it's not diagnostic per se, it's just a finding that would require additional diagnostic workup, in my opinion. But I'm not a radiologist, so they might tell you otherwise. But to me, as a pathologist, to diagnose something, imaging is key to pinpoint the lesion, the area of the lesion. But then usually you have to go for another set of diagnostic workup, including cytology or a core needle biopsy, and send it to the pathologist. So to me, it could mean so many different things, and it doesn't have to be, alarming in that sense. But that's something for a radiologist to answer, actually.
Got it. I have a question that you may be able to tackle. It's about treatment, which I know is not what we're really talking about today, but also about genetic mutations, which we have talked about a little bit. Glenn says, I would like to find out more about targeted treatment research, excuse me, for genetic mutations for high-grade NEC, neuroendocrine carcinoma, such as BRAF.
Yes. Yeah, there are studies available. If you search on PubMed or any of these official libraries where you publish studies, there are a few studies, and they're coming more and more. Studies in which what you do is you collect a certain number of cases with neuroendocrine carcinoma, and then you extract a DNA, and then you look for these mutations. And some of these mutations will change the protein in a way that you can actually target that tumor type with a specific drug. And the drug or the genetic change that's described here, it's called the BRAF mutation. That's a specific mutation in a gene that will cause the tumor to grow rapidly. And now we have a treatment called vemurafenib. It's a BRAF inhibitor. Basically, it binds directly to the mutated BRAF and kind of reduce the activity of the BRAF protein, and then will reduce the proliferation and cause the tumor cells to die. So there are studies ongoing, and that's one of the genes that that I actually was referring to when I talked about that we interrogate the DNA of these NEC patients, and we look specifically for BRAF to see whether or not it's mutated, because that would, in theory, make it suitable for this BRAF inhibitor treatment. But there are studies out there. I can happily help you out to send a few of you to the Carcinoma Cancer Foundation later.
Yeah, no, that'd be great. And please feel free. And this applies to Glenn or whomever. If you have follow-up questions, or your question didn't get addressed today, please reach out to CCF. You can message them here on Facebook, just a private message, or you can also reach them at carcinoid.org, their website. But thanks for sending them in. From Sheila, have you seen nets hiding in the diverticula?
Yep. Yes. It's actually a quite aggressive neuroendocrine tumor that can arise in the diverticula of the intestine. It's in the Meckel's diverticula. It's a specific net tumor. What the Meckel's diverticula, what it is, it's an embryonic rest in which you can actually have a gastric tissue. Gastric tissue in the small intestine. So in that gastric tissue there, you might have neuroendocrine cells that might malignify and turn into a carcinoid or a net tumor. So I've seen a couple of those cases, and usually what's known about them is that they're a bit more aggressive than other net tumors arising in the small intestine. But they're just as curable, but they're just more aggressive. So I've seen a few of those cases.
Got it. Thanks, Sheila. From Donald, is it possible to diagnose nets without pathology?
That's a great question. I wouldn't recommend it. I mean, of course, if you have radiology and you would have if you had a clear-cut lesion in the pancreas, which would lit up like a Christmas tree when you have this somatostatin receptor imaging, the chance of it being a net, of course, would increase. But to me, pathology is 100% the truth. I mean, we're wrong from time to time, but you need to go to pathology. So I would not recommend you diagnosing a neuroendocrine tumor. Of course, these, you remember I talked about pheochromocytomas and abdominal paragangliomas. They excrete norepinephrine and epinephrine, adrenaline. So basically, those patients, you can actually have a very high suspicion of these tumors preoperatively because they will have symptoms of very high adrenaline in the bloodstream. So that, you can be more or less sure, but you wouldn't have to have pathology or cytology in order to pinpoint the diagnosis correctly.
Mm-hmm. Speaking of pheochromocytoma, Arlene says that my surgeon told me results after my 2010 pheochroma surgery was inconclusive. Why would they say that?
The surgery was inconclusive, or the pathology?
The surgery, but I'm just curious if you have any thoughts on that.
Well, the pheochromocytomas, they're really tricky tumors. Mm-hmm. So they're extremely, they're not that hard to diagnose, but they're really hard to prognosticate. So when she got her original surgery, it was 2010, right? Mm-hmm. 2010. At that point, you talked about malignant and benign pheochromocytomas. Mm-hmm. Now, what we know today is that all pheochromocytomas are potentially malignant. You just have to grade that. You have to stratify the risk of malignancy. So that's we're not discussing malignant or benign pheos anymore. We call them. They all have a malignant potential. Most of them have very low malignant potential, will never spread, but there are a few that might. So if the pathology report is inconclusive, it might be that they're not sure whether or not this has a metastatic potential or not. The surgery for pheochromocytoma is usually, that depends on the tumor size, of course. Yeah. Some pheochromocytomas are 10, 15 centimeters, like giant pheochromocytomas. So the surgery can be really complicated. So I don't know if that was what the surgeon was referring to.
Yeah, that's a tough one, I know, but just wanted to see how we could address it. Thank you for your question. This is just a comment, but definitely one worth sharing. Donna says, loving the information and discussion. Great to have the expertise of a pathologist. Dr. Juhlin communicates so clearly. Totally agree.
Thank you.
And we've got about 5 minutes left with him. So go ahead and keep sending in your questions, but I totally agree that the answers have been spot on today, and I appreciate your manner as well. There's a follow-up from Jean or Jeanne. Let me know if I'm pronouncing that correctly, please. Thank you for your thorough response. See, does it mean right now we can't even know if the grade has changed or if there was a different sampling? This was to that previous question. Okay.
Yeah, well, I wouldn't worry too much about that. It's more or less of a hypothetical scenario. Okay. That is something we try to address now in research studies. So if you have a large neuroendocrine tumor, we're trying to address that in a research study. And what we're trying to do is that we take like pieces of every half centimeter, and we investigate that for proliferation to see if the grade is different. And we try to assess whether or not you should be able to assess the grade in different areas or not. But the standard procedure now recommended by the World Health Organization is that you stain one area in which you see a lot of mitosis, and then you count in the hotspot area. So usually we're spot on. You don't have to worry that your grade might be different. Usually that's not a case. It's just a theoretical, mind-provoking thought that we need to address in a study. For most cases, neuroendocrine tumors are fairly small when excised. So usually we embed all the tissue, so there's no problem that we won't miss anything. But for the real large bad boys, there might be some areas that are not sampled because they're too large to just process in the lab.
Got it. Thank you. Laura says, have you seen any links between NETs and Lynch syndrome?
Oh, that's a great question.
And let's establish what Lynch syndrome is, if you don't mind.
Sorry. So Lynch, Lynch syndrome is it's an autosomal dominant cancer syndrome in which you have a mutation in one out of several genes that will make sure that your DNA is not damaged too much. So basically, it's called they are DNA repair proteins. They walk around the DNA in your cell and they make sure everything is fixed. It's like a plumber, make sure everything's working fine. So there's no damage here, there's no damage there, that's fine. What happens is in Lynch syndrome patients, they will have a mutation, an alteration in one of these repaired genes. So the protein will not function properly, meaning that they won't repair, these damage in the DNA occurs all the time spontaneously. So you need to have these guys walking around the DNA strands and fixing stuff, but they won't in this case. So then you will accumulate mutations, and these patients will develop bowel cancer, large bowel cancer to a large extent, and also tumors of the thyroid and other various organs. And I know that I've seen a few patients, Lynch syndrome patients with neuroendocrine tumors, but I'm not sure there's an actual link. You need to ask a clinical geneticist or an oncologist about that. But it would make sense in a way, because if you have a damaged DNA repair system, of course, you will accumulate mutations in various cells in your body. And that's why these Lynch tumor syndrome patients have so many different tumors amassed in them. Yes.
Got it. Thank you. Probably time for one or two more from Bethany. Any information about the environmental factors on the pathology of tumors that may contribute?
These are so. I'm writing down everything you're saying.
I told you.
I'm learning. No, I have very, very little information to give you about that. I don't think there are that. First of all, I'm not the guy to answer that question, but I would say I'm not sure there is a clear-cut link between neuroendocrine tumors and various exogenic factors and environmental. Probably, we know that. Develop a tumor in the human body, it's partly bad luck and partly also influenced by external factors like your diet, smoking, all these different matters for tumor development in general. But I'm not sure if that goes for NET tumors. That's a great question. I need to read up so much after today.
As I alluded to at the beginning of the program, the benefits and value of this show is twofold: information from our guests and also experiences and stories shared by our community, by our attendees. So folks, a couple of people responded to that. Brian responded to that and said stress and reduction of stress has been very helpful for him. Jim chimed in and said, I couldn't agree more. I do meditation, counseling, and float therapy as needed, which I wanted to chime in about, because if you haven't, this is weird for some people, but float tank therapy is like on another level. If you haven't heard what it is, check it out. Are you familiar, Dr. Juhlin?
Oh, I'm not.
It's like a capsule. It's a float tank that is filled with, enough salt so you float in the water, right? So it's just a little bit of water, but you float on top of it and they close you in. Some people, if you're claustrophobic, you can keep the door open, but it's a little capsule and you just float in darkness for 60 to 90 minutes, which is strange for people, but it's like, if once you get to the point where you're calmly doing it, it resets things in a major way. So I've done that several times. Just wanted to chime in, but folks, I'm really proud of you all when you share those experiences with each other, because sometimes there are questions that are better, better answered that way. You never know it. Different things help different people, especially with these environmental factors that we're talking about. So just wanted to say thanks for that. Okay, before we go, one last question. I know you're involved in research a lot. Anything that you're working on from the research standpoint that you're excited about that's like could lead to some breakthroughs in the next few years?
Okay, so very short. Yes, I'm very excited that we have implemented second generation neuroendocrine markers in our diagnostic lineup based on research that we and others have been doing. So I started this talk with this Grimelio silver stain in the way to highlight the neuroendocrine tumors in the 70s. Now, then we have the first line of neuroendocrine markers, and now we have the second line, which is coming more and more. So we're very happy and proud that we have been able to play a small role in implementing them in the clinical routine. And also we have a bunch of studies going on in pheochromocytoma, paraganglioma, and also neuroendocrine carcinoma, in which we have found additional prognostic markers that are only expressed in the most poor prognosis cases. We'll try to reproduce now in the clinical setting to see if they might highlight these cases before they spread or disseminate and respond poorly to treatment. So that's something I look forward to.
Got it. Thank you. Well, a lot of people are chiming in about how great of a show it has been. I agree. A lot of people say they want to rewatch the replay, or if you missed it, the show, as soon as this is done, will be posted. I want to thank, first I have to give a shout out to Ritva from Finland, who says Tusen tack, which is to our Scandinavian friends. 1,000 thanks. Everybody is chiming in. We'll send you some of the information, but folks at home, this is the end of Dr. Juhlin's day, as he hopes. He is about 6 hours ahead of us here in New York time. So we definitely want to thank him for having a long day at work and then still spending this hour with us. Everybody had such a great time today, but thank you so much for being here. I'm really, really excited for the show that we just had.
Thank you so much. And thank you all for having me here. I think it's so important to just let a pathology speak with you directly. I've missed this, the interaction with patients. So thank you so much for having me. I feel that I learned so much from this as well. So
this is what it's about. This is why we love bringing the show. So thanks to you all at home as well. Really, I mean, honestly, such a great job today. And I love this because it's a dance, right? It's a collaborative art, this thing, and we're going to get through this together. So I appreciate you all being here, and we hope this program helped answer some of your questions. I'll reiterate one more time, reach out to CCF either here or at their website if you have follow-up questions. And thanks as always to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. Finally, my name is Rain Bennett. Thank you for watching. I have been your host. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.